Hello everyone, I'm Shane Mills, Director of Quality and Mental Health and National Collaborative Commissioning Unit. I'm here to show some of the work we've been doing with the Strategic Programme of Primary Care about mental health and primary care. I've been working with Julie Denley, who's the Director of Primary Care and Mental Health in Cwmtaf, and we've been working through a subgroup of the Programme of Primary Care, Mental Health and Wellbeing to talk through some of the demand that's happening in primary care, particularly related to mental health. We have a group with representative from the Strategic Programme of Primary Care, the Third Sector, Welsh Government, Mental Health Collaborative, my unit, the National Collaborative Commission Unit, and the Delivery Unit. Today I'm going to talk through the 5 areas we've been working on. We've been looking at demand and activity in primary care for mental health issues, the needs of individuals presenting at primary care for mental health issues, the provision of services by the NHS in primary care, the variation between those services provided by the NHS in primary care, and the provision of services by the third sector. When we talk about mental health and wellbeing in Wales, just some facts and figures to look back. In 2015, 13% of individuals living in Wales reported to be receiving treatment for mental health. A 2015 survey of GPs in Wales said they spent about 20% of their working day dealing with mental health issues. In 2017, GPs expressed concern that they cannot deal with the increase of mental health workload and were feeling less confident in managing mental health complex cases, particularly with external factors such as unemployment and debt. The pandemic, of course, has hit us all, and especially mental health. So a 2021 pandemic found that 20% of people reported feeling lonely, 13% of people were having thoughts about and feelings around suicide, and 1 in 6 children aged between 5 and 16 were found to be struggling with their psychological well-being. There's obviously, we're going into a cost of living crisis and possibly a recession, and there's long-term evidence that during these times there's a strong association with poor mental health and well-being. Today I'm going to talk around sort of tier 1 services, but that's quite complex. There is a definition for tier 1 which you can see on the slide, but actually I'll talk around how these are interlinked between tier 0, tier 1 and tier 2. And of course we can't forget that education, social care and physical health service play a very large part in the delivery of safe and effective services for those with mental health issues. In terms of what's happening around that tier 1, we can see in the yellow square at the top, we have mental health and wellbeing services that are available to all. These aren't services based on any deficit or any need, but they're to enhance wellbeing and people's quality of life. We have social prescribing, seen in that green circle there. We have social prescribing services available in Wales. These, again, not always based on a deficit of mental health, but are there for a strength-based approach, there to empower individuals to take a part of their community. The thing I would talking mostly in the slide set is around the red circle, primary care, which is normally a sort of deficit of mental health for non-urgent common mental health issues. Those terms are nebulous, but they are terms we'll use. And in the blue circle, you can see there, we have secondary care mental health services normally delivered by the NHS, where there's a deficit of mental health of a serious or urgent nature. In terms of demand in primary care, we looked at a 5-year and 8 months of worth of data through the SAIL data bank. We can see there on the slide set, when we looked at 5 years, that line shows at least a 6% increase of those with a recorded mental disorder. And it's important to say not everybody with a mental health issue will have a recorded mental disorder. You can see in the slide set, the blue area is the first lockdown of the pandemic, and you can see a significant drop off of people seeking help from their GPs, and obviously we know that pathways into help were disrupted during the pandemic. And the orange there is the longer lockdown we had at the end of last year. You can see that drop off there, and then a significant bounce back in terms of people seeking help through their GP. In terms of a bit more around the SAIL databank data, the top right hand slide there, you can see the blue donates females and the red donates males. More females were more likely to seek help than the males, and this is normal sometimes in primary care. About a third less likely males to seek help for mental health. The bottom left hand side, the 5 colours donate deprivation quintiles, where purple is the most deprived, or people from the most deprived addresses, then black is the next most deprived, and then red, blue, red and green then in order. And you can see there an absolute correlation with the purple of people from the most deprived areas seeking help at their GP for mental health issues. In terms of another area of demand is the local primary care mental health support services. These were put in place around a decade ago to support people at a primary care level for mental health. And you can see there a significant increase of around 60% pre-pandemic, a decline during the pandemic, and then a bounce back post-pandemic. And you can see there we're having about a 60% increase in people seeking support for local primary care. We have a target in mental health that 95% of people should be seen within 28 days. The only time we've been close or to hit that target was in June 2020. This may suggest that local primary care schemes are suited to a capacity of around 2,000 to 4,000 a month, and they're currently running around 7,000 a month. So they're significantly exceeding their capacity as they were planned a decade ago to achieve. If we talk around those people that seek help from primary care, where they go afterwards, we can see in that top slide there that around 40% of males are referred on to NHS mental health services and about 30% of females. If you look at the bottom right hand graph there with the deprivation quintiles, if you look at the purple and the black line, you can see that people from the most deprived areas are most likely to be referred to NHS mental health services. And you can see this area there during the pandemic. After a significant decrease at the beginning of the pandemic, people from the most deprived areas are far more likely now to be referred on to mental health services. And this could be because of their complexity of needs and that they have concurrent conditions like debt, loneliness, housing, and other areas of concern. We have the call helpline in Wales, which is the community advice and listening line. And you can see there, if we look from 2016 to 2019, the first 4 years, we had a very steady number of calls to that helpline. You can see the pandemic, so the last couple of years here, we have had a 37% increase in 2020 and another 17% increase last year. So altogether around about a 50% increase in people calling this helpline for support for their mental health issues. Another area of looking at demand is to look at prescriptions related to mental health that are dispensed in the community. So we can look at a baseline there of 2016, and you can see antidepressants since 2016. We've had a steady increase each year of antidepressant prescribing. Antipsychotics, the same. We've had a steady increase in antipsychotic prescribing. This could be related to access to medical support, like psychiatrists at a primary care level, or it could be because of prescribing patterns. Anxiolytics, which are used to address anxiety in others, we've seen a decrease. That could be because we've substituted those prescriptions for others, or it could be because people can access help for anxiety through different pathways. ADHD, which we know causes lots of concern to our primary care colleagues, we've seen a significant increase in prescribing for ADHD medication. We can see there hypnotics, and we've seen a significant decrease over the last 5 years in hypnotic medication prescribing. These medications are normally for the support of sleep disorders. And we can see there that that might be related to their recognition of their addictive qualities, or their substitute prescribing for other medications, or access to help and support for those type of disorders. So that's the side of 5 year sort of metadata. If we look now at some work we did at looking at individuals presenting and their particular issues, we undertook last year a 2-day survey, just of 600 patients over 2 days who had accessed their GPs, and GPs very kindly completed this survey. About 350 responses were received from GPs, and we looked at those mental health practitioners that are based in practices that again are referred on for people like receptionists and others, so they don't need to be referred from their GP. We look at just in our survey, the majority, so 62%, came from that 26 to 64-year-old age group, and you can see there those percentiles from different ages. Around 63, so again about 2/3 were from females, so again that aligns to the metadata we saw where males were less likely to access their GP. Of the issues that were recorded for the 622 patients, there was about 1,500 issues, which is about 2.5 issues per patient. So people aren't coming for one issue, they're coming from several issues, the majority of people. We grouped these issues, these are loose groupings, we group these issues into different areas. You can see there on the top left box, mental health issues, which we would expect were the majority. That's the survey was around mental health issues, and again there you can see the percentiles that came with anxiety and depression, and the vast majority of people came with that as an issue, and then self-harm, eating disorder, psychosis, dementia and postnatal. About 6% of people had a substance misuse issues. Remember that people can have more than one issue, but 6% of people had either a drug or alcohol misuse issue. Neurodiversity, the bottom left there, around 5% of people had a neurodiversity issue, whether that be ADHD or a learning disability. 17% of people came with trauma, or what we've linked as trauma and complex mental health. So that's people with long-term traumatic experiences and adverse childhood experiences, and people with personality disorders or complex psychological issues. And the top right box there is welfare issues. About 4 in 10 people had what we've counted as a welfare issue. That's relationship, bereavement, employment, housing, school, education or debt issues. So about 4 out of 10 people came with a welfare issue. This rather complex table there, which I won't spend too long on, shows the interconnectedness between all those issues. And you can see there with things like ADHD and dementia, about a third of people came with just that issue. So they didn't come with any other correlating issue. But with things like anxiety, 17% of people had another issue. So people aren't just coming with anxiety, they're coming with issues, and you can see the correlation there. And just for interest, you can see there with domestic abuse there, you can see a link with suicide and trauma. So I'll leave that graph for you to look at your own leisure. In terms of a difference in our survey between males and females, with the blue top line denoting females and the gold denoting males, you can see there females, this is an odds ratio, so females far more likely to have anxiety and depression, and males far more likely to have relationship, employment, alcohol misuse, debt issues, or psychosis and serious health issues. In terms of any difference between what the GP saw and what the primary care worker saw, remember this is not a randomised control trial, so it could have been that these are just the issues that people came with, but we wanted to see whether there's any link. It will be a hypothesis that primary care workers have slightly longer, between 20 and 40 minutes with a patient than a GP. Are obviously busy working through their lists. And you can see the primary care worker there, which is the gold, far more likely to pick up trauma, ADHD and alcohol. So does a longer time give you the ability to pick up those more complex issues? In terms of where people went in this survey, this is kind of a rule of threes. So you can see that top bit of the graph here. You can see about a third of people did not require any onward referral, either from the GP or the primary care worker. The GP in this slide is in gold, the primary care worker is in blue. You can see in the middle bit here that about a third of people needed a referral onwards into the NHS. And then that bottom bit of the slide there, about a third of people either were asked to self-refer or had an onward referral into the third sector services. In terms of which conditions were more likely to have an onward referral to the NHS or an onward referral into third sector, with third sector being the top, the blue bit of this, you can see there anxiety, depression, employment issues, bereavement, alcohol misuse and debt issues were far more likely to have an onward referral into the third sector. And as maybe would have been expected, eating disorder and psychosis or complex psychological conditions were more likely to have an onward referral into the NHS. We also asked for any feedback from GPs there, and this is just a snapshot, just 6 quotes from our GPs. Again, I can let you read this at your leisure, but GPs were noticing an increase in mental health needs at a GP level. There were also with some comments there around the disrupted pathways that community mental health teams were declining to see people. Obviously, these are just comments, personal comments from GPs, and that the long waiting list were making GPs use different pathways or having comments around the impact of those long waits for appointments on their own ability to see patients in a timely fashion. In terms of the provision of services by the NHS in primary care, so these are not local primary care mental health support schemes, these are local primary care mental health support schemes. This is just an example of Cardiff. We looked at the 6 health boards where these schemes were in place, so I won't linger on this, but it just shows the information that we were looking for. So again, summarising, the 6 out of 7 health boards have some form of primary care service in place. They've all got different names, these services. They've all got different types of practitioners. And again, there might be even the same type of practitioner, but with different names there. So you can see psychological wellbeing practitioners, ICANN workers, mental health liaison workers, primary care workers. The referrals into these services were mostly by GPs, but in some cases by receptionists or self-referral. Most of these services were delivered by digital, by telephone, but most of them had a face-to-face provision. The waiting times for these primary care services range from the same day to 3 weeks. The interventions offered by these services range from signposting to stress reduction, coping skills and motivational interviews. The outcome tools used by these services range from none in some areas to triage or simple questionnaires to some more complex mental health outcome tools like the Core 10 or PHQ-9. The numbers of staff employed by these services range from 4 to 27, and my hypothesis is the numbers of staff were more related to the funding available than to the actual ability to meet local need. The bandings, so the range of staff skills range from band 5 to band 7, and again they range from non-registered graduates, psychologists, occupational therapists and mental health nurses. Where some health boards had tried to plot the number of practitioners per GP, they would use a scale of between 16 to 24,000 registered population per practitioner, but that was not consistent and it was not across all schemes. We worked with the Welsh Institute of Health and Social Care at the University of South Wales to undertake a literature review on what are the principles of a positive primary care scheme. And during that literature review, and you can see the details at the top of that slide, they looked at 5 main principles that made a positive mental health scheme. Whether the scheme was accessible, so how difficult or easy it was. If it was easier, it was more positive. The communication between the patient and practitioner was found to be a pertinent factor, so the better communication was found to be a more positive scheme. The capability of the practitioner in terms of their skills and their competence and their confidence was found to be more positive. The buy-in, not only by the patient and the practitioner, but by the organisation and the GP practitioners, was shown to be a more positive factor. And the resources that were available to the practitioner in terms of staff, room, time and funding was shown to be a positive scheme. We're now working with the Welsh Institute of Health and Social Care to look at the 6 schemes in place in Wales and to see how closely they align to those 5 main principles. Looking at the provision of services by the third sector now in primary care. Third sector is a term used to describe a range of organisations that are neither public or private sector. We mapped at least 450 groups. It was constantly changing because new groups are coming all the time that primarily deal with mental health or wellbeing issues. Since many groups can support people with different needs, we found at least 1,200 pathways from primary care into the mental health third sector. Awareness of these schemes came from local staff and local knowledge to internet services, directory of services, the Association of Voluntary Services and the Welsh Alliance of Mental Health. The range of these services came from very local, very small self-help groups to nationally delivered services. The staffing of these services were ranged from volunteers to trained practitioners. The cost, which was always difficult to work out of these services, we identified at least 25 million from the NHS budget that was used to fund mental health third sector services. But the other funding came from local grants, from GP clusters, from local contracts with local authorities. The variable commissioning, some of these services were very well commissioned with service specifications to meet other needs. Others were more long-term services that had grown from local need, but there was a significant variation in the commission of these services. We looked at the onward referral permissions, and the normal is that they were not what we call trusted assessors, so they weren't able to do an assessment that was recognised by either the primary care mental health schemes or the local primary care schemes or secondary care mental health schemes. The outcome tools used were normally from small groups activity counts, but others used things like the recovery scar or core 10 or core 34. We looked at the age range. So again, we looked at those groups. So about 300 of the 450 groups particularly dealt with a certain age cohort. And you can see there through the 7 health boards, the initials of those health boards are in gold on this slide. We looked at whether they predominantly dealt with older adults, or children and young people aged 0 to 4. We found about a third supported young people, 42% supported adults, and about a quarter supported older adults. On this slide, you can see what we endeavoured to do was to map, so the blue boxes, the main areas that the third sector organisations stated that they dealt with. So that's anxiety, depression, domestic violence, etc. And the red line here is our findings from the survey. So we were trying to correlate whether demand, as we found from the survey, mapped the provision of services from the third sector. What's a good thing on this slide, it shows that nationally we don't have any gaps. So there's no areas that we found in our survey that weren't being dealt with by the third sector. But you can see there are some differences between the demand felt through our survey and the local provision of services. So next steps. So again, summarising all the data that I've talked around in this slide set. And going back to the 4 circles, we can see that we look at wellbeing issues. We found that people from the most deprived areas were more likely to attend a GP for a mental health and wellbeing issue. When we look at social prescribing, we found that welfare issues were often concurrent with mental health. So again, you can see there's lots of overlap between the third sector pathways that are used by social prescribers and the third sector pathways that are used by our primary care mental health schemes. In terms of the red circle there, you can see that we found that at least a 50% increase in referrals to local primary care schemes over the last 5 years. 40% of people have a welfare need. There are at least 1,200 third sector pathways from primary care, and significant variation across or even within health boards and clusters in the provision of primary care services delivered from the third sector and from the NHS. In terms of the blue circle, we found at least a 6% increase of people presenting at a GP with a mental health diagnosis. We found that 30 to 40% of GP presentations are referred on to the NHS, and 10% more people from the most deprived areas are referred on to NHS mental health services. And you can see our arrows there. We've also got to consider online support and same-day primary care, which are more newer services that are being developed in Wales. We're here today to ask your opinion around our next steps. So we've got 6 areas we want to see if you recognise and agree with. So our first area is, do you recognise what I've talked around today in terms of the increase in demand and complexity, the variation in provision, and the multitude of pathways that you've seen in the slides? Is there a need for consistent terms and mental health schemes? Have we had an increase in complexity of the system that is not helped by having different names of practitioners and different names of primary care schemes? And do we all understand what we mean by primary care mental health schemes, Tier 0 and Tier 1? Do we need to be clear on the pathways into and outside of primary care and how primary care is linked to third sector education, social care, social prescribing, and secondary mental health care? Is there a need to be more consistent in the commissioning of third sector services? How do we ensure that third sector provision meets local demand? And how can we do more to optimise the use of third sector provision at a primary care level? The 5th question there, is there an appetite for stakeholders to develop and implement a national consistent offer for primary care so that we're all absolutely sure about what will be delivered at a GP or a cluster or a GP practice? We know the pathway those services, we know what these services will deal with, what their offer is, and how they link to other mental health services. But as you've shown through the deprivation and other areas I've talked about, how can we ensure any national consistent offer can also be enhanced to take account of local need that might be happening at local services? In terms of our next steps, I'm here today to engage with yourself as stakeholders, and we'll do that through the summer months of this year. A national report will be published after our engagement that will take into account all the feedback received through these engagement events. We're making an interactive map of all the data we've shown today available in the summer months. and we'll identify key areas for inclusion in the planning process, the NHS planning process, and we will ensure that we engage with clusters about commissioning opportunities and next steps nationally, and we'll do that by September 2020. Thank you very much. I'm Shane Mills, and you can contact us with the details below. Thank you.